To talk about partial breast irradiation, let me just remind you one very important thing. Today, the standard treatment is whole breast irradiation, delivering 50 grays in 25 fractions, or an equivalent of this dose, in addition to boost to the tumor bed or the initial tumor bed for 16 grays in 8 fractions. This is after, of course, conservative surgery. And discussion about lymph node irradiation is also really important. However, you can see if you go to the PubMed, you will find the recent publication on these issues from France and from the USA. And of course, this is discussed essentially for patients with node positive. Now, if we want to move and to try to find new options in breast cancer radiation, one is, I think, the most important one is partial breast irradiation, either using external techniques but also intraoperative techniques. And we are going to deal during this presentation with the concept, the rationale to develop this kind of concept, the techniques we can use, and I will give you some data published recently and conclude with some take-home messages. So what's about the concept? The concept small is more sometimes and better than strong. And the concept is changing the paradigm in breast cancer is, of course, like in surgery, moving from radical surgery to conservative surgery, and now probably in the next years moving from whole breast radiation for accelerated partial breast irradiation. And I think that would be probably a very important point before moving is what is and who are the patients who will really benefit from this kind of paradigm change. If we look at the surgery and to the history here, you know that probably the first surgery for breast cancer is like 5,000 years earlier, and we have one of the first reports in terms of breast cancer surgery in the 3000 before Christians. You can find it in the Arab word books, 2000. And since that time, as you can see it here, we had significant evolution in terms of multidisciplinary approach of breast cancer in terms of radiation therapy, but also hormonal manipulation. And the first application in brachytherapy after X-ray discovery was 40 years. So we had 40 years between the first discovery of the X-ray and the first brachytherapy application. Here, if we want to focus now only on radiation therapy, what you can see on this slide is the advances after conservative surgery are summarized here in terms of the time. You have, of course, after surgery, external beam radiation therapy, which is the standard, and in general, 4 weeks or between 4 and 8 weeks after surgery, we start radiation therapy and give it during 6 or 7 weeks. We have new options like hypofractionation. You all probably see the paper from Canadian and the English start studies comparing the standard treatment in 6 weeks to 3 weeks with similar results, and particularly in the Canadian study at 12 years with no difference in terms of recurrence. And now here this new option, instead of giving radiation therapy during 6 or 7 weeks, here giving the radiation therapy during only 1 week after surgery, or even during surgery with an intraoperative technique. I will not go here in this issue because I will otherwise I will need much more time, and I will only focus on this part of evolution. What is the rationale? The rationale is, of course, this slide is usually used by the people who are in opposition to partial breast irradiation, but it is also used by the people who are who defend the partial breast irradiation. You probably saw this paper, very old paper, in which they look at the invasive and non-diffuse cancer in 130 patients with pathologic size less than 2 centimeters. What you can see here is, if you are away from the tumor, you decrease significantly the probability or the percentage to find another small tumor in the breast. This means if we have a small tumor, this is the first message from the slide, small tumor in the breast, the probability, if we take out this small tumor, to find something else down in another quadrant of the breast is very low. The second publication, which is very important also for the rationale, is of course the Milan study. What you can see here in this randomized trial, including 567 patients with a tumor less than 2.5 centimeters, randomizing between quadrantectomy alone versus quadrantectomy plus radiation therapy. The local recurrence at 12 years was 6%. And if you look at here, you have only all these recurrences mainly appeared in the same quadrant, as you can see it here, mainly in the superior quadrant. Only 5% were seen elsewhere. In the rest of the literature, you can find many other publications looking about the site of the recurrence after breast cancer. You can see here that mainly more than 70% of the recurrences are seen in the same quadrant and not elsewhere, which means that probably if we cure the patient with surgery and local treatment, maybe we will not have recurrence with partial breast irradiation. But however, if you look at this this series with 16 years or more than 12 years, you have a significantly higher rates of recurrence, but probably they are not true recurrences, but a new secondary cancer in the breast. Another point for the rationale is the advantage we can have from accelerated partial breast irradiation. Of course, we can define the target volume, we can spare the organ at risk better, we have less time to decrease the inconvenience for the patient, but also for the department, in which we are going to eliminate the scheduling problems, probably with the systemic therapy, and also to reduce the load of crowded linear accelerator in this 3D CRT, and in some part in the world, when we have only one linear accelerator for a large population, we need, of course, to have the disponibility of the linear accelerator for the rest of the population, and probably lower cost. So, however, this is slide of Abraham, and While whole breast radiation is clearly established as a treatment, as a standard treatment with a long track record, safety, and which is level 1 evidence-based medicine. However, in the world, when you look at what is happening now, is many centers, and particularly in the United States and Europe, already carry out the APBI on a regular basis. If you have time, you can go to this, for example, to this Mammocyte website. You can, where they describe, of course, the balloon, the technique of high-dose rate brachytherapy using this device. You will find that about, as you can see it here, about 32,000 women have been treated with, out of the trials, with this technique at the beginning, and of course now with the time, with the American trial, the US trial, the RTOG trial, which will include more than 6,000 patients. All the patients are entered in the trial, but at the beginning of the history of the Mammocyte, people, and particularly surgeons, did many treatments out of the trials. But I think that in all cases, the patient selection is a crucial step to have the good results in the future. If you don't select the patients for this kind of procedure, you will probably lose the benefit you may have from the innovation. If you look at here, just an example for patients, if we want to select them from their age, what you can see here in the trial published in 2004 in New England Journal of Medicine, the trial comparing tamoxifen versus tamoxifen plus radiation therapy after surgery. What you can see here, if you select these patients more than 60 years, it is a subgroup of particular patients. What you can see here, when they have a small tumor less than 10 millimeters and hormone receptor positive, at 5 years you have even no difference in terms of local recurrence. This means that if you select your patients on the basis of the tumor, hormone receptor, and the age, maybe you don't need at all radiation therapy in some patients. And moreover, if you look at the other trial, this is, of course, have been published I think in 2008. You see that the patients who are more than 70 years, for example, they will not die from the breast cancer. They mainly die from other cases, and particularly cardiovascular disease. And if they have more than 70 years, small tumor, hormone receptor, this trial shows that there is no difference between these patients in terms of survival, because these patients will die from their comorbidities and not from their breast cancer. Now, what is the techniques? The techniques, you have more than 50 ways to do partial breast irradiation. You have here the catheter-based brachytherapy using high dose rate, low dose rate, pulse dose rate. You have Mammocyte, I showed you already the device, and you have the 3D conformal radiation therapy, either using prone or supine position, IMRT. You can also use proton therapy, like it has been developed in Boston, for example. You see here all the techniques. As it is shown here, the difference, instead to irradiate whole breast, you will only irradiate the tumor bed using here 4 or 5 fields, and the patient here, it's the New York and Formanti technique, where the patient is in a prone position. And you can see that with this technique you can omit completely the lung, And you have also another technique which use two felts and one direct electron beam developed by Alphonse Tarion in Boston. However, before any applications or regular application, we of course need data, and we need data. And if you look at the history of the data, you can find these first publications in where, as you can see it here, there were really discouraging results, because you have local recurrence 37%, 25%, and these are very, very bad results, of course, in terms of local control in breast cancer. And why? Because in these two studies from England, the problem was the selection of the patients. There were many patients who had positive margin and large tumor more than 4 centimeters and so on. So this is the first publications. Of course, now we don't have this kind of results because of the better selection of the patients. However, if you look at the 3D versus IMRT published also last year, I think in 2009, you see the small number of patients, the follow-up relatively short. And what you can see here is that you have, in some publications, unacceptable rate of toxicity in these patients, because the technique is not adapted to the volumes, and particularly, and in some patients, not adapted also to the tumor site, like inner quadrants or lower quadrants, for example. So we need more better selection of the patients with the stringent criteria. We have to take into account all the prognostic factors, and particularly the margin size and nodal involvement. And I remind you that for example, in the RTOG trial, they also include patients with node involvement 1 to 3, and they stratify on this factor. The treatment and quality of insurance is very important. More uniform dose prescription, organ at risk definition and sparing, better target volumes uniformity, greater ability to define the target, but the learning curve and quality of insurance. This last point is very, very important. We can absolutely not start to do partial breast irradiation if we are not sure that we have the experience, and we compare our dosimetric results with the teams who have already developed or who have already did this routinely, for example. And in terms also of selection, we can also have a guide from the guidelines and the consensus statement published by the ASTRO and the JAC Astro for low risk. What you can see here is, for example, in terms of age, for example, more than 60, more than 50 here for the JAC Astro. The tumor size is different. However, if you look at the Astro consensus, which is the first one who has been published in 2009, they defined from this in this publication from 645 original research, 38 published prospective single arms studies. They defined 3 groups: the suitable group, the cautionary group, and the unsuitable group. Here are summarized the criteria. The suitable group for Astro is here: more than 60 years of age, T1, not negative, ER receptor positive, and the margins more than 2 millimeters. This criteria, probably we can move and do partial breast irradiation routinely. Here you have the cautionary group with 50 to 59. As you can see here, the larger tumors we still with negative, we are negative hormone receptor negative, margins less than 2 or less than 2 millimeters. The presence of DCIS less than 3 centimeters, and lymphovascular lobular are not allowed to have partial breast irradiation, and this unsuitable is the rest of the population, as you can see it here. Here are again if they are summarized the suitable group criteria, and this is also just to show you in this publication all the results published here using different APBI technique, and 3D is here. What you can see here is the median follow-up is still short in some of the studies. Here are the majority of these studies. We have between 2 and 9% of recurrence, and here the results, which are mainly good to excellent in the majority of the studies. If you summarize, this is from a slide from Vicini. If you summarize the interstitial mammocyte and 3D conformal radiation therapy, you summarize here almost 5,000 patients. If you look at here the ipsilateral breast tumor true recurrence, you are between 0 and 9%. It's exactly what we obtain with whole breast irradiation. Again, you have to be careful for patient selection. Now, what's happened with the cautionary group? The cautionary group, this is a recent publication in the Red Journal, where they took 136 patients, where they have 1/4 of the patient with multiple criteria. More than one criteria discriminate this subgroup of patients to be in the cautionary group. The treatment consisted of high-dose brachytherapy, mammocyte only 7%. This is an interesting shift in terms of high-dose brachytherapy. At the beginning in the United States, many patients received high-dose brachytherapy using mammocyte, and now they are shifting to the multi-luminal, because I think that I personally conducted a phase 2 with mammocyte in France, and we know that the results are a little bit different from the multi-luminal, particularly regarding the tumor site. In the inner cadron, you can absolutely not insert the balloon. For example, you cannot insert it in the inferior cadron, for example. Also, and it is a little bit difficult now to I think, for the mammocyte company to go on and to sell more and more mammocyte, as they did it at the beginning of their history. The median follow-up of this series, focusing on the cautionary group, is here. If you look at here, the 5-year actuarial ipsilateral breast to recurrence was 4.8%. The disease-free survival is okay, 90%, 97% for overall survival after 5 years. Now let's have a look on the tumor. What they saw that if you have tumor here, invasive alone or DCIS plus in DCIS subgroup, there was 0% of recurrence, while the 6% in invasive. This means, of course, there was not significance because a retrospective study probably with biases. However, what you note here is that the patients who were treated with brachytherapy for partial breast irradiation for DCIS, 0% of recurrence. The second one, if you take only the age alone, you have 0%, but however, if you add to age For example, the one prognostic factor from pathology criteria, you increase the risk to 12%, and the difference was significant. This means even you have cautionary group, maybe some of these patients, if they are 50 years old and no other parameters, maybe they became a suitable group. Here I just summarize all the trials that are now in the world. What you can see here is the number of the patients which will be included. You see here the 9,000 patients that are planned in the RTOG. It will be one of the most important in SABP RTOG trial. It will be one of the most important trials in the history of partial breast irradiation, because they include large population with stratifications we will really have, and I think that they need just 1,000. They are very in advanced step to finish this trial, and we are conducting one in France, comparing with 3 arms. Partial breast irradiation versus standard irradiation versus hypofractionated irradiation. So 3 weeks versus 6 weeks versus 1 week treatment. So what we can say is that the multiple single and multi-institutional data have been published indicating good and excellent long-term results using APBI. However, we have to select the patients in terms of tumor, age, and so on, in order to decrease the risk of recurrence, and probably other criteria for the morphology of the patients in order to decrease the toxicity. Long-term results of large phase trials comparing APBI are still pending. You saw the number of ongoing trials. And for those patients eligible to receive accelerated partial breast irradiation, enrollment in these trials is encouraged. However, for those not eligible, guidelines have been proposed now in the literature from Jekestro and Astro to select these patients and probably to propose them this treatment of protocol. So finally, this is what I told you at the beginning about the advances in surgery. We probably have more things to get in the future. In terms of radiation therapy, we are moving here slowly to accelerated partial breast irradiation. There is another issue which is very important to take into account, which is coming now. It's intraoperative radiation therapy. You have surgery, you remove the tumor, you have one fraction, the surgeon closes the tumor bed, and for a while, no more treatment. And also, I think that the possibility in the future to try to find really biologic parameters that could discriminate again the high risk of recurrence in order to omit to propose limited irradiation. And thank you for your attention again. I invite the young students to Istanbul next meeting, and it will be, of course, free for them. Thank you.